I thank Dr. John Martin for displaying fantastic surgery, a parachute technique. We'll go to the next session, which is on interesting case scenarios. Okay. I request Dr. Shrish Pathak, Dr. Arumugam sir, Dr. Sundarajan, and Dr. Amit Joshi to chair the session. I request Dr. Mahesh Krishnan as well. Would you mind joining us, sir? Please. No, interesting case. We want your opinion.
Chairperson, please involve the delegates, and not just the faculties alone. Let the delegates also come out with their opinion first. It's a learning point for them.
Thank you, sir. So let's go on to the first interesting case. 62-year-old female patient, right hand dominant, and pain in the shoulder for 7 years, gradually progressing and weakness. And for the past 3 months, she is not able to lift the shoulder. So chronicity. The clinical evaluation, there is wasting in supraspinatus, tenderness present at the Codman's point, the bicep screw. She is having active range of motion, but it is painful. The cuff power, there is weakness elicited in supraspinatus and infraspinatus. The subscapularis is normal in power, but pain, tenderness is present. This is the X-ray. Any other views the panelist would expect for the X-ray, sir? We'll start with Dr. Mahesh Krishnan and then follow it up with Dr. Shrish Pathak.
At that AP, I would like to get a little more rotated film, a true aggression film, yeah. And the lateral, the head is almost centered. So I need to get a better AP view.
Okay, fine. If the AP, say, take for instance, if the AP is normal, so what would be the next investigation of choice?
Yeah, I think first of all on clinical signs and symptomatology history, I think 7-year chronic, so I have got some differential diagnosis in my mind. One I had was osteoarthritis. Chronic OA, so probably it is ruled out over here.
Absolutely.
Second is a rotator cuff pathology because supra-infra is weak. So I'm looking at probably a small tear which has progressed over years and now she is unable to abduct the...
An acute on chronic kind of situation.
Could be. Third, I would not even would like to rule out the cervical spine pathology because that C5-6 days over the period also can give this kind of weakness and presentation.
Okay.
So yes, so next line of management would be to get MRI scan or at least a screening sonography on OPD basis if not possible.
Do you concur with that, sir?
You said supra is wasting.
Supra wasting is noted.
Isolated?
Isolated.
No infra?
Isolated supra wasting.
No infra?
No.
Isolated supra wasting without involving infra is a very rare scenario. It never happens in chronic metabolic situation. It usually happens in some mechanical impingement. Otherwise, all of the pathologies that involve rotator cuff pathology usually will have predominant infra or equal infra-supra involvement. So isolated supra
maybe a
is
chronic supra, recent infra?
Chronic supra, recent infra. Hypothetical too much, but I would like to think more about some mechanical or, as Shirish said, some cervical.
We don't have any superior migration, so it does not fit well.
Okay.
Yeah.
So let's proceed to the MRI scan. We have the coronal image and the axial.
Maybe our delegates, one of them can comment.
One of the delegates can answer this MRI scan. Can you read the MRI scan? Yeah. Thank you, doctor.
It seems to be complete full thickness tear of supraspinatus tendon.
Absolutely.
Biceps tendon appears to be in location, present in location.
Correct.
Subscapularis seems to be partially torn.
Absolutely correct.
Infraspinatus looks intact.
We have to go sequential slices on the coronal section to validate the infra. And your comment on the tissue quality now?
This coronal, right? And there seems to
Sagittal.
be type 2 fatty degeneration.
Fatty
The line
degeneration.
drawn along the superior part, muscle is below
That's
that.
atrophy.
Atrophy.
Yeah.
Yes, it's atrophied.
Yeah.
Yes.
So always make it a point to look at this view, not just this view. We have to assess the muscle quality in other sections also, but this is the predominant view that we have to check in for. The muscle, the tangent sign is negative, which means there is some amount of muscle which is going above the line. But look at the quality of the muscle bulk. There is no fatty infiltration. So, so shows that it's a good quality tissue. Any comments from the panelist?
So, passive range is full.
Yes, yes. No
Active
stiffness.
active is
Painful.
pseudoparalysis.
Active range of motion is present, but painful.
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 Not painless pseudoparalysis. It's a painful,
Painful.
pseudoparalysis.
Yes,
Your subscap on clinical testing was 5/5.
it was intact.
An MRI shows diffuse fatty streaks here and infra and subscap.
Yeah.
Such a situation is usually seen in some brachial plexus,
So suspecting cervical.
cervical, panplexopathy, something like a Parsonage-Turner syndrome, something like that.
Okay.
I mean, I don't know, but
But-
it should
but,
produce a painless
there's-
pseudoparalysis.
there is
But
detachment
there
of
is
the-
a subscap
yeah.
is torn, LHB is dislocated, supra is torn, so obviously supra and infra is torn. Some superior migration of the humeral head, some findings of RCTA, cuff tear arthropathy, some flattening of the acromia, the GT, some flattening is there. So it's a chronic, massive anterosuperior cuff tear involving subscap, long bicep, supra, infra with early signs of cuff tear arthropathy, maybe.
The diagnostic scoping. Sorry. Video is not playing. Video is not playing.
Maybe you can tell us the findings.
Diagnostic scopy showed a partial thickness tear of Lefau's type 2 tear of the subscap, not a full thickness tear. That was the reason why the subscap power was good, but though the MRI scan showed partial uncovering of the lesser tuberosity, so just tricks us. So the quality of the MRI scan is very important. So in this condition, the axial view did not show the complete integrity of the subscap in a very clarified manner. So what I'm trying to stress is get a good quality MRI scan first to come to a conclusive diagnosis. Next thing is the importance of if the video is not playing, I can use my laptop and do it. Just like this.
Yeah, so I think for subscap, I always depend on two clinical tests. Gerber lift-off, if it's a full thickness whole tendon involved, then it's probably more sensitive specific. So belly press is a very important clinical sign for me, because that can tell you upper third subscap tears, whether they are present. So I think I would not just go by strength, because of pain you can't rely on the strength of subscap. So I think Napoleon belly press sign is a good option to diagnose partial tears of subscap.
Sir, what about belly press? Okay. What about
Bear hug as well,
bear
both.
hug, isn't it bear hug more sensitive in the upper subscap?
So yeah, so what they have said is it's not a one test, combination of two out of three is the best.
Right.
So bear hug, and if belly press is positive, I'm sure it is upper subscap.
Yes, and the lift off also, persistent lift off and holding, and
Yeah.
it would be more sensitive than just a lift off.
No, but see, with this kind of painful ROM, many times you can't take their arm on their back. That is the problem.
Right.
Yeah, absolutely. Full thickness subscap. Yes. belly press is better.
What about the modified belly press? Nothing. Okay. All right. So the diagnostic scopy shows full thickness supraspinatus. Of course, the pulley is compromised. There is a type 2 Lafosse subscap tear. So just going on to show about the importance of the landmarks of subscapularis. Always the upper two-thirds strongest portion. Complete compromise of the tendon, which is, as explained, if the lift off is positive, then there is complete compromise of the upper two-third, which means you can expect more than type 4 kind of Lafosse tear. And some of the signs to check out for an subscap tear is presence of sclerosis along the lesser tuberosity in the axial section. And in chronic cases, you can see subchondral cyst formation in the MRI scans. That will give us a clue of something wrong with the subscap attachment. And of course, in these kind of cases where you can see the bridging sign, which is positive in a full thickness tear. Then we did the scopy, repair of the subscapularis tendon from the joint. We didn't want to go subacromial and do it. The lesser tuberosity bird, we used a bio anchor and then took lasso stitch through it and fixed it. Then we did a subacromial decompression, and there was a small reducible supraspinatus tear, very well reducible, and then resorted to just simple single row repair. So always keep in mind, full thickness subscap tear, belly press, Gerber's lift off test will be positive. A partial thickness tear or now type 2 or lesser than that, it's very difficult to diagnose clinically. So we need to have a good MRI vision, one, and we need to have a sensitive and a specific clinical examination test. One is the bear hug, other one is the belly press or the modified belly press test. So that will give us a clue on to suspect subscap.
Because you mentioned the sclerosis in the MRIs, this were also there. And in the coracoid showing a slight sharpening there.
Impingement.
So it's definitely a subcoracoid impingement, and coracoid decompression might also be an additional thing.
Absolutely true, absolutely true. So when these signs are positive, we are justified in doing a subcoracoid coracoplasty. When it is not, then it may be an additional procedure. So this is one take-home point. So identify the subscap tear preoperatively. It's very essential. Even if it's a partial tear, we have to repair it because it restrains the anterior force couple. Any type of repair as per the reducibility is according to the surgeon's comfort level. Second case, we have a 67-year-old male, a retired officer who is right hand dominant. He has got injury to the right shoulder for the past 2.5 months following a road traffic accident, and he had a dislocation. And that dislocation was reduced under GA. He was immobilized for 3 weeks, and now he is not able to lift his shoulder. So, dislocation in an elderly patient. What are the suspicions, panelists?
If in elderly literature clearly says that beyond 40 years, whenever there is a dislocation, you must suspect a rotator cuff tear. In this group
Valid,
of
valid,
and then
very
the
much valid.
incidence increases exponentially beyond 40 years.
Okay. The other most important finding is elderly patients with dislocations always have a high index of suspicion for a Hagel tear, because the arm position is not like the young patients following on outstretched hand. They usually have hyperextension. So just because of maybe of weak muscularity, the arm position predisposes their shoulder to a Hagel tear also. So we have to have a high index of suspicion. So on clinical examination, the wasting, there was deltoid, supraspinatus and infraspinatus, and there was tenderness present in the Codman's point, AC joint, coracoid and the biceps groove. So the active range of motion, external rotation to 20 degrees, not more than that. External rotation, abduction 10 degrees. It's all because of pain. And then internal rotation to the back is only to the SI joint, and abduction only up to 80 degrees. So definitely movements are painful as well as restricted. So the subscap, infra, supra, all are weak. Sulcus is negative. That's X-ray. Sir, your comments on the X-ray, AP view. Now this time it's relatively true lateral.
Let us have
To AP.
from delegates. Do this find something?
Yes, anyone, please. Giri.
X-ray AP view with superior migration of the humeral head, some
Mild breakage in the Shenton's line, yes, or the Gothic arch, yes.
mild breakage in the Gothic arch and some osteophyte below the glenoid.
Osteophytes. He had a history, right? History of dislocation.
Probably
So-
bony Bankart.
Okay, good. So there is something suspicious in the antero-inferior part of the glenoid, and the Gothic arch seems to be broken to a certain extent. And axial view,
Head appears centered.
yes, of course.
Some reverse, some Hill-Sachs defect is seen in the.
Okay, so the X-ray shows as a anterior bony Bankart as well as a Hill-Sachs lesion.
With the superior migration.
Correct. Thank you. So the MRI, we got a picture of a Bankart lesion along with a massive cuff tear. In the coronal view, any of the delegates, can you please read the MRI scan, please? Prashant?
Sir, MRI shows superior migration with the cuff tear. On the coronal cut, on the sagittal cut,
Axial.
on the axial cut, the biceps tendon is out of the groove.
Yeah, the secretary is dislocated.
Yeah. And yes, there is bone loss also noted over the anterior glenoid margin. Probably I will put it somewhere around 85 to 90. I mean, bone loss should be around 10 to 15%. So other stuff, yes, there is a Hill-Sachs also noted, sir.
So, how can we conclude on the diagnosis?
So diagnosis, yes, the patient's history of dislocation correlates with the MRI image, and as discussed earlier, it also corresponds with the rotator cuff tear. So managing, I would plan.
So
Bye.
it's an elderly patient with a massive cuff tear, dislocated biceps, and it's dislocated medially, medial dislocation. So
Yes.
the medial pulley is lost. So have a suspicion of medial injury also, with a Bankart lesion and a Hill-Sachs lesion.
Yes, sir.
So how would the panelist approach this case?
No, Sham, I would like to see the T1 SAG.
I have restricted films available, so
And
Sorry for
in
that.
view of bony Bankart, I would like to have even CT scan also, because that is very important. I need to know what is the fragment size and whether I need to tackle that as well.
absolutely, I totally agree with you.
CT is mandatory because in elderly, the bony Bankart is more common than bony Bankart is an osteochondral injury associated with a labral injury. So that that bony fragment, what is evident on MRI will be bigger on CT sometimes. So
Right.
it so as to be qualified as an intra-articular glenoid sometimes. So in an elderly individual, so CT.
So CT is
as-
mandatory,
yeah.
mandatory when you suspect anteroinferior glenoid chip in an elderly patient with a dislocation. We have an axial view that shows that definitely there's a glenoid bone loss. The diagnostic scopy. There is a presence of the anterior inferior glenoid defect which is seen. Seems to be not a major glenoid defect. Definite presence of a full thickness supraspinatus tear. That's what's been found in the diagnostic scopy, and if you can see clearly, the long head of biceps is showing fraying here. It's frayed in the groove portion, which means it has dislocated. So the long head of biceps is not normal. So we proceeded with the long head of biceps tenotomy. In this case, would you want to repair the anterior bony Bankart lesion? Repair of anterior bony Bankart lesion along with a cuff repair.
Yes, I think so. It's a significant bone piece. You can't leave that.
Okay. So we proceeded with the supraspinatus repair. The subscapularis was also compromised. It was a Lefau's type 2 tear in the subscap. We did the subscap repair from the intra-articular portion. And that's the reason why the biceps was dislocating. That's the intact subscap. But what the literature says is that a rotator cuff tear associated with anterior capsulolabral lesion ranges around 11 to 15%, and were found in 93% of elderly patients with recurrent dislocations. Nevertheless, the most important finding is we believe that the large cuff tear is the culprit. Though the patient has got an anterior bony Bankart lesion, imbalance in the cuff is the most important component for recurrent dislocation in an elderly patient, not young patient, elderly patient. So this literature suggests that it can be dealt without a Bankart repair. A cuff repair can be done without a Bankart repair. So that's how we followed it, and the scenario has totally changed over a period of these 10 years, because this surgery was done 7 years ago. So 7 years ago, we were thinking, okay, cuff repair is good enough. No need to address the Bankart. But now things have changed, and now it's more robust, and we feel everything is significant, everything needs to be fixed. So if asked this question 7 years ago, this is true. But now our thought has totally changed, that we have to fix the cuff along with the Bankart repair. That's what I think is a valid option for a treatment strategy. Would the panelists agree with that?
Yes. And what one should not do is lethargy, just because technically this bony Bankart, because I had few patients,
Yeah.
similar picture,
Yeah.
and someone who was not confident to do both at single go, he went open and he thought it's a significant bone loss, why not to do a lethargy?
Correct.
So I think it's a crime to do lethargy in a 65-year-old
Never touch that, never touch that. But the question is, things have changed rapidly. 7 years ago, we were saying something. Now we are totally changed that opinion and come to this kind of an opinion. 7 years ago, it was just cuff repair, that's enough. Now it's do a cuff repair, do a Bankart repair, bony Bankart repair also. Don't worry about the stiffness. That's a message.
Yeah, my question was like, do we have literature saying that, see, bony Bankart agreed. Suppose it's a soft tissue Bankart. So then, okay, because if we tighten up the ligaments, isn't there a chance for definitely stiffness? And shouldn't we do just a cuff repair and look for stability, and then we should go and suppose it's no bony Bankart repair, no bony Bankart at all. It's a soft tissue Bankart. Then and if the shoulder is stable through the range, then I think you should leave it alone. That was
Absolutely.
my-
Totally agree with that. Totally. Bony.
Yes, definitely, it's a bony
Because it's a
Bankart.
bony one. Yeah.
Sir, one more question to ask was, suppose it's a bony Bankart, suppose it's a neglected bony Bankart. So patient is coming to us after some time, maybe like 3 months, 6 months, maybe a year. So question is again, the bone could be resorbed. Then what do we do? It is unstable. Isn't that a case of cuff repair plus lethargy?
See, if it is a chronic presentation with subluxated joint or recurrent dislocation, then probably I may think in terms of replacement also in very select few patients. Because it is very difficult to address significant bone loss with large retracted subscap supra infra with arthroscopic procedure. So you have to have a good long discussion, counseling, and then go for the decision.
We actually had one particular case where we had a significant instability. Bony Bankart was there but neglected. So we did a massive repair, plus we did a lethargy. Patient went on to do extremely well.
It presents like two scenarios. One, that patient comes with second time dislocation. It can happen. In which scenario you have to repair this instability static labrum with the cuff, definite. Bony Bankart, you have to repair both. But soft tissue ligament injury, as you said, with cuff tear, you do an apprehension test.
I should check it out.
Yeah, the
But
clinically
why
it's stable.
wouldn't you fix the soft tissue Bankart with the cuff? If you're going to worry about the stiffness, you're going to get the stiffness with the cuff repair. You're already there, already in surgery, in an Indian scenario, already there, just fixing two ankles with the soft tissue. That question of, again, dislocation, future, doesn't occur.
I don't think stiffness is a concern in the repair of both. Stiffness should not be a concern, I think so.
Well, I want to add the same in the same point of view, like what Shyam says. This old literature shows that to repair only cuff, but we don't have any randomized study. We don't have clear evidence to should not do a Bankart repair. Because 2 months before I operated one case, a 63 years old female operated for cuff repair, but patient had a soft tissue Bankart, not even a bony Bankart, came with a recurrent dislocation.
Correct. It's happened. It has happened.
I
So
did
that's
instability
why,
surgery for that lady, even
Correct.
though it's an old lady, but she's 63 years old.
Yes. So one more.
So I think stiffness is not a criteria to do a not to do a Bankart repair because my experience.
Sundar,
if
you can't call 63 years old. Very soon you'll be near that.
So I am 53 only.
63 years, not old. 63 years.
I think what I just wanted to add is we have to look from case to case. This was classic of first time dislocator with rotator cuff.
Yes.
You can have a first time dislocator with bony Bankart and the rotator cuff. You can have a recurrent dislocation with the rotator cuff. So when it is a recurrent dislocation, probably it is mandatory to do a Bankart repair as well as the rotator cuff repair.
Absolutely.
If it is a first time dislocator, as we know, 67-year-old, chances of recurrence is extremely rare. If it is just a soft tissue Bankart, I would leave soft tissue Bankart and repair the rotator cuff alone.
Correct.
But since this patient has a bony Bankart, so this is the time to attack at the time of rotator cuff repair.
Yeah.
To add is, if you have such patient, especially for beginners, acute dislocation, you have reduced, and many times I have got this patient was sent home and nobody bothered to look at that patient. She dislocated again at home and went back for a follow-up after 3 weeks. Then situation completely becomes more challenging. So it is mandatory to have post-reduction good true AP and have a follow-up visit immediately after 3-4 days to make sure joint is stable and well reduced. Otherwise, these are patients with bony Bankart and cuff tear to have immediate second dislocation maybe in hours or days.
Correct. We are looking at the glenoid rupture from the glenoid side. Now let's go to the other side. Humeral rupture, Hagel lesion. It's very common in patients who have cuff tear with a Hagel lesion. How would you manage that?
Hagel in elderly. Yeah, I've never done.
We have done 3 cases. Maybe it's rare, but still, the point that I want to say here is the Western surgeons. I interacted with Dr. Sumant Krishnan, then with Dr. John Kenny. They say, don't worry about the Hagel lesion. Okay, just fix the cuff. Hagel lesion is a scary picture. It may give you a scary picture. It may make you think that the shoulder may dislocate even if you repair the cuff. But in an elderly patient, don't worry about the Hagel lesion. It may lead to stiffness if you try to repair it. Just fix the cuff and come out. So, because it's a rare condition, you may not see, but in case if you see, the way to handle it is just fix the cuff and come out.
Sir,
Because of Hagel repair, yeah. Correct.
But
Correct.
Hagel is capsular, as you say.
Capsular, yes,
But
absolutely.
it automatically heal. It might heal automatically.
Yes,
And
chances is
also,
there,
I think
yes.
we are not identifying at all. I have not come across cuff tear with Hagel.
It's
but
seen in
maybe we are
acute
not
case scenario, it's very easily detectable because of the hematoma which acts as a contrast. But if it's left for a longer duration, it's very difficult to pick it up unless you find the loss of J sign.
On this bony Bankart, only if it is displaced, you need to repair it. If it is not displaced, then you don't need to repair at all. You can leave it as such.
Sure.
Sir, again pertaining to this case, so we are already talking about repairing the rotator cuff and the Bankart lesion, and stiffness is definitely a concern. Would you also add a remplissage to this case, or you think the rotator cuff repair and a Bankart alone will do the trick?
Just repair.
No
Don't do a
remplissage.
Don't do remplissage. Yeah. So case 3 is now 52-year-old. Yes, sir. Yes, sir.
The first slide, when I asked the question, when you see a case like this, what are the things you suspect after the clinical picture, no? The most important thing for the youngster to examine for the axillary nerve.
No.
Because many times in the cuff tear patients can have this axillary palsy, and if you go and do a repair, then after 3 months also they will not do lifting. Then you wonder, then if you go and touch, they will have a patchy sensation because many times it's missed. But if it is missed, even you should do a repair, but you should counsel the patient that you have a problem of your nerve also.
Yes, sir.
So it's very frank dislocation patients.
Correct. There are elderly patients whom we have seen, many subset of patients who had dislocation related cuff tear with a brachial plexus traction injury. So that's a problem. So that's a different entity which we need to treat. Where the brachial plexus is a traction injury. Now let me give a situation to you all. Now we have a patient, elderly patient, say around 67-year-old, who has got a full thickness cuff tear and he's got a brachial plexus injury. What is the plan of action? Would you consider that the brachial plexus is injured, let the nerve recover and then I repair the cuff? Or I repair the cuff and wait for the nerve to recover and then he will come back to normal position. What is your option?
Yes, okay. We had, I'll take the question because
Yes, please.
we had a similar case recently because very atypical presentation. The patient has come to me like gives a history of like 3 years pain and documented MRI rotator cuff tear. So, and which was done like I showed, and she was advised surgery with a grade, possibly a grade 1, grade 2 retraction 3 years back. Again, underwent physiotherapy, felt better, but again, after a year, again counsel for rotator cuff repair. She didn't do it. Then she came to me like maybe 3 months back with a history of fall. The patient, when patient came to me, this got a massive rotator cuff tear, and at the same time with pseudoparalysis. It was very difficult because we look at always the cuff because a history of trauma, cuff, and maybe that's why she's not lifting. But when we documented it, we found that definitely there is an upper trunk, patchy upper trunk brachial plexus. So we did a cuff repair, and then we waited on for 6 months. And at the end of 6 months, now we had to do a nerve transfer because she didn't respond adequately.
Yeah. So whenever possible, whenever there's a cuff tear along with a brachial plexus injury, try to restore the cuff. Give it some chance for the nerve to recover. If it doesn't recover, the nerve transfer will definitely help you out. So always fix the cuff. That's a take-home message.
There is one point to it. If the cuff is repaired and waiting for 6 months to heal, what is the point in cuff recruitment? It's not happening. The entire cuff will be denervated and fatty atrophy will happen. You are repairing the cuff and recruitment has to be started. Only then that muscle fatty atrophy has to go in and has to put it back. So that plexus palsy means it's totally denervated. What is that you are gaining by repairing the muscle which is totally denervated? Just by maintaining the anatomy. That's one question to you.
Correct. We need to provide the chance for the muscle to survive.
Accepted. Agreed.
Correct.
Yeah, I think that is very.
So the carry-home message, this is too
patient.
much complicated. So carry-home message is don't miss bony bankard and don't miss cuff tear in elderly dislocate.
I will tell one more. I think basically
neurological examination.
What you have to do is you have to explain to the patient very
Absolutely
well.
must. Absolutely
You have
must.
to involve the neurologist and yourself, rehab, and clearly explain to the patient about the overall outcome. Explain that it will take 6 months to 1 year minimum.
Absolutely.
Because
Before you put the knife.
That is what very important in this. Yeah.
In such an unstable situation, would you do LHB tenotomy or you would preserve LHB? Because LHB may be used if it's a
Tenotomy,
massive cuff tear, biceps.
I mean, it
Long
depends on
biceps.
perioperative finding.
Yeah, would you do an LHB tenotomy or you try to preserve LHB tenotomy in this particular scenario?
I wouldn't do tenotomy.
I mean,
Unless it is badly inflamed. And I would.
Let us stick to basics. Let us stick to basics. That is too advanced.
All right, we just have 4 more minutes. 52-year-old female, homemaker, right hand dominant, fall on outstretched hand 3 weeks ago, pain in the right shoulder and she's not able to lift her arm. That's because of the pain. Rest pain is positive. She's developing stiffness. I would say it's painful stiffness. The patient had a shock-like sensation in the right shoulder while trying to abduct once. Shock-like sensation. And ever since the incident, she felt apprehensive while abducting the shoulder. This is the classical history that she gave. Any clue from the history? Delegates, any clue from the history what has happened to her? A shock-like sensation. I would say that the shoulder just moved out and came back in. So that is one sensation which they get. And painful walk positive, apprehension positive, anterior load is grade 1, and active range of motion reduced due to the apprehension. In the cuff status, there is weakness in the supraspinatus, empty can is positive, subscap infra is normal clinically, X-ray looks okay, nothing abnormal, MRI scan. Now let's go to this. Presence of anterior capsulolabral disruption, which is seen in the MRI scan, and there is presence of a supraspinatus tear. All right. The most interesting part is there is fracture in the glenoid rim extending from 3 to 6 o'clock, and there is a partial width tear at the supraspinatus. CT scan says there is no obvious defect or flattening in the posterior-superior aspect of the humeral head to suggest a Hill-Sachs lesion. Do you believe this report? There is a presence of a bony Bankart. A bony Bankart will not occur without a Hill-Sachs lesion. So the report is wrong, in simple words. So do not go by the report. Just go by a clinical diagnosis, assessing the mechanism of injury, and then coming to or expecting a proper report. So if you go by this CT scan, then you wouldn't suspect an instability. That's the thing. So in this case, we have obviously seen that there is a anterior capsulolabral disruption. So rightly, as discussed before, we went with the anterior capsulolabral repair, and then we did a cuff repair. So now this one says arthroscopic Bankart repair, let it be a bony Bankart or a soft tissue Bankart in a younger age group, repair both. So this is the current literature. So that one 7 years ago was a different literature. At current situation, this is a different literature. 57. Old. All right. So just I'll go to the last case, a very interesting case. I'll show you this one. Now, this is 55-year-old male, right hand dominant, and dislocation in a private hospital which was reduced, and he continued to have pain. I'll quickly go through the apprehension positive, drop arm positive, Jobs positive, everything is positive. MRI shows a cuff tear, massive cuff tear, everything is ripped off, and CT scan. Delegates? Babur? Part of? What is that lying next to the humeral head? Can you see the coracoid? Fracture of the coracoid. The severity of injury is so bad that he has got a fractured coracoid along with a massive cuff tear. So what we did a CT scan, we checked if there is any anterior bone loss. Hill-Sachs is definitely positive. So we directly went for open it up, deltopectoral approach, fix the coracoid, fix the cuff. So the take-home message here is, do not hesitate to open the shoulder. You want to fix everything, open surgery is still a valuable, valid option. Yes. Subscap is repaired with the anchor. The rest is transosseous, fiber wire. Yeah. So if there's no question, I will end this session and I will pass it on to Dr. Santosh for continuing the session. Thank you very much. Thank you.